Welcome to the deep dive. Today, we're really getting into the nitty-gritty of vascular surgery, specifically how surgeons actually access the arteries down in the leg and thigh.
Yeah, it's fascinating stuff. Our main source here is the big one, Rutherford's Vascular Surgery, 10th edition. Think of it as a look behind the curtain.
Right. Understanding the anatomy, the challenges. It's incredibly detailed work. Our mission really is just to appreciate that complexity,
Yeah.
the skill involved.
Absolutely. And look, it might sound super specialized, but knowing about this stuff, lower extremity arterial exposure, tells
Yeah.
you a lot about surgery in general.
How so?
Well, these aren't rare procedures. They're done all the time for things like intermittent claudication, that leg pain when you walk.
Right, restricted blood flow.
Exactly. And much more serious things, too, like acute limb ischemia, where blood flow just stops suddenly, or critical limb ischemia, which is chronic and really threatens the leg.
So surgeons need a whole toolbox of ways to get in there.
Totally essential, especially if it's a redo surgery, or there's infection, or the patient is obese, or it's a trauma case. You need options.
Okay, so before we jump into specific arteries,
Yeah.
what are the sort of golden rules, the basic principles for any of these exposures?
Good place to start. Yeah. There are definitely some fundamentals. First up, the incision. It just has to be long enough.
Makes sense. You need room to work, see what you're doing.
Precisely. Trying to operate through a tiny hole, that's asking for trouble, accidentally nicking something.
Okay, adequate length. What else?
Self-retaining retractors. Almost always. They hold the incision open for you.
Like little hands, keeping things out of the way.
Yeah, exactly. Frees up the surgeon's hands. And a sterile Doppler probe.
Ah.
Continuous wave type.
The little ultrasound thingy to find the artery.
Spot on. It's like sonar. Helps you pinpoint the vessel, especially if you can't feel a strong pulse. Indispensable.
Okay, got it. See clearly, know where you are. What about, like, managing the tissues on the way down?
Right. So liberal use of cautery. That's key.
Using heat to cut and seal blood vessels.
Seals off the small bleeders as you go. Keeps the field clean, much easier to see. Big exception, though, don't use it near nerves.
Right, risk of heat damage there.
Definitely. And any lymph channels you cut, tie them off. Ligating them stops fluid leaks later.
Lymphatic leaks, okay.
Then meticulous hemostasis just means stopping all the bleeding.
What?
Super important.
How's that achieved? Just cautery.
Cautery helps, but it's also basic surgical technique. Traction and countertraction, pulling tissues gently apart to see better.
Creating that bloodless field you mentioned.
Exactly. And careful dissection right next to the artery. Using sharp instruments, blunt ones, just gently separating things.
So you can get control above and below where you need to work.
Precisely. Need enough space to put clamps on safely, or to do an anastomosis, that's the connection for a bypass.
And you mentioned avoiding clamping calcified arteries.
Yeah, if you can help it.
Yeah.
Heavily calcified, like pipe stem arteries. Clamping them can actually crack them or cause damage. Not ideal.
Wow, okay. And what about handling the vessels themselves, especially if you're using a vein for a bypass?
Oh, absolutely critical. Vein conduits need really gentle handling, meticulous care.
Because damaging the vein graft affects how well it works long term.
Unfortunately, yes. So gentle handling, good lighting is crucial, and magnification surgical loops, basically fancy magnifying glasses.
Especially for those tiny connections, the anastomoses.
Exactly. You need to see every stitch.
All right, let's zoom in. Starting at the top, the femoral artery. Where exactly is that, and what are the landmarks surgeons look for?
Okay, the common femoral artery, or CFA, it's deep, right under that crease in the groin where your leg bends the inguinal skin fold.
So it's coming down from the abdomen.
Yep, it's a direct continuation of the external iliac artery, passing under the inguinal ligament, that strong band of tissue.
And its neighbors.
Right. In the upper thigh, in the femoral triangle, the CFA sits medial towards the inside of the femoral nerve and lateral towards the outside of the common femoral vein.
Nerve, artery, vein,
Right.
navel. Right. From lateral to medial.
That's the classic mnemonic. Yeah, all three are wrapped in the femoral sheath. And that whole triangle area is covered by muscles like tensor fascia laterally, adductor longus medially, sartorius diagonally across the front.
And this common femoral artery then splits.
It does. It bifurcates into the superficial femoral artery, the SFA, and the deep femoral artery, the DFA, sometimes called the profunda femoris.
Okay, anatomy clear. How do surgeons actually get to the CFA? What's the usual way in?
The most common way is the longitudinal approach. Basically a vertical cut right over where you feel the femoral pulse, just below the inguinal ligament.
What if you can't feel a pulse?
Good question. You can usually still find it as a firm, sort of tube-like structure, usually a bit medial to the midpoint of the ligament.
And the incision length. How much above and below the ligament?
Typically, about a quarter to a third of the incision length goes above the ligament, the rest below. But here's a really key point, especially for obese patients.
With the pannus, that fold of tissue.
Exactly. You have to identify the true inguinal ligament first. That pannus can make it look lower than it is. If your incision crosses that skin fold, big problems with wound healing. Major risk.
Ah, okay. So pinpoint the ligament first. Then what?
Then you divide the subcutaneous fat directly over the artery. Avoid making skin flaps. They don't heal well either. Then you tie off any small vessels you see, superficial epigastric, circumflex, arteries, and veins.
Standard cleanup.
And ligate lymphatics, too. Always ligate the lymphatics you cut. Minimizes leaks.
You mentioned the saphenous vein earlier. Where does that fit in?
Right, the great saphenous vein. It's usually medial on the inner side of the artery here. So you need to dissect carefully on the lateral side of the artery to avoid hitting it.
Especially if you might need it for a bypass later on.
Exactly. Keep your options open. Then, deeper down, you hit the fascia lata, that strong tissue layer. You cut that medial to the sartorius muscle, enter the femoral sheath, and there's your artery.
What if you need to see further up, more proximally?
You can gently free up the inguinal ligament and retract it upwards. Sometimes, rarely, you might have to cut it, but if you do, you absolutely must repair it properly at the end.
And to see the top of the SFA.
You can mobilize the sartorius muscle and gently pull it laterally to the side.
Okay, that's the longitudinal way. You also mentioned a transverse approach, horizontal cut.
Yeah, that's useful when you only need, limited access to the CFA.
For what kind of procedure?
Maybe a femoral embolectomy, getting a clot out? Or for the small cut down needed for an endovascular aneurysm repair, EAR.
So how does that work?
You make a horizontal cut, maybe 2 finger breadths above and parallel to the ligament. Go down, find the ligament, retract it upwards. Then dissect down over the pulse until you hit the femoral sheath.
Open the sheath lengthwise.
Yep. Self-retaining retractors are really helpful here. You can usually get good access to the CFA itself, but seeing the SFA and DFA origins is definitely more limited with this approach.
Okay, let's move down a branch. The deep femoral artery, the DFA or profunda. You said conventional and lateral approaches. Tell me about the conventional one first.
Right. So the DFA usually branches off the CFA about, say, 2 to 5 centimeters below the inguinal ligament. It tends to head laterally towards the outer thigh.
And the exposure starts like the CFA one.
Exactly. You use that same longitudinal incision. As you expose the CFA downwards, you look for the DFA origin, usually on the lateral or maybe posterolateral side. Often where the CFA seems to narrow down a bit as it gives off the DFA and SFA.
How much of the DFA can you usually see this way?
You can usually expose a few centimeters pretty easily. Then you often run into the lateral femoral circumflex vein.
A vein crossing over the artery.
Yeah, frequently crosses right over the front. You have to carefully identify it, tie it off, and divide it to see further down the DFA.
Any other structures to watch out for?
Might be other crossing veins to divide. You might need to retract the sartorius laterally again, ligate any lymphatics, and always be careful of the femoral nerve nearby.
Don't want to injure that.
Definitely not. The length of DFA you can expose varies, maybe up to 8 centimeters sometimes, and it tends to branch more the further down you go.
What about those circumflex arteries, medial and lateral?
They usually come off the DFA itself, but sometimes they pop right off the CFA near the DFA origin. So you have to be careful with dissection on the back side of the vessels there. Don't want to accidentally injure them.
Okay. And the lateral approach to the DFA, when would that be the go-to?
The lateral approach is really valuable for redo surgery.
When there's scar tissue from before.
Exactly, or infection. If the usual proximal area is just a mess, this gives you another way in, maybe for inflow or outflow, or if you need a more distal inflow point, say if your vein graft isn't long enough to reach from the groin.
How's the incision made for this one?
It's parallel to the sartorius muscle, maybe 6 or 7 centimeters down from the femoral pulse, or just below where a previous incision ended. Could be medial or lateral to sartorius, depending on where the graft needs to go.
Give me an example.
Okay, maybe lateral if you're doing a profunda to anterior tibial bypass or an ax-fem bypass down to the profunda. Medial if it's maybe a fem profunda jump graft or profunda down to the popliteal.
Gotcha. And the dissection path.
You need to dissect lateral to the superficial femoral vessels and the nerves there. Bit more risk of nerve injury from retractors in this area, actually.
Be gentle.
Very. Then you go deeper between the vastus medialis and adductor longus muscles. Often there's a seam, a raphe where their fascia meets. open that up.
And you find the DFA?
Well, you usually find the deep femoral vein first. The artery is typically deeper still. If it's tricky to find, that handheld Doppler comes in handy again. Listen for the flow.
Makes sense. Okay, let's track the other main branch, the superficial femoral artery, the SFA. Proximal approach first.
Yeah, the proximal SFA is pretty straightforward. It runs deep to the sartorius muscle over the adductor longus.
So you just extend the CFA incision downwards.
Exactly. Extend that longitudinal groin incision further down the thigh. The SFA is right under the upper part of sartorius. Just mobilize sartorius, retract it laterally, and you're there.
Can you get to it without exposing the CFA first?
You can, yeah. Make a separate incision a bit lower down along the front edge of sartorius.
Okay. And further down the SFA, middle and distal parts. You mentioned the adductor canal, Hunter's canal.
Right. The SFA runs through this sort of tunnel, Hunter's canal, between the thigh compartments. It's formed by the fascia of vastus medialis, sartorius, and adductor longus.
What else is in there with the artery?
The femoral vein, it's usually deeper, maybe a bit behind the artery, and two nerve branches. The saphenous nerve for sensation, and the nerve to vastus medialis muscle.
How do you set up for this exposure?
Patient's leg is turned outwards, knee bent maybe 30 degrees. Make a longitudinal cut parallel to the front edge of sartorius. Careful not to cut its blood supply, which comes in on the lower inner edge.
Then go through the fascia lata.
Yep. Cut the fascia lata, find sartorius, retract it backwards. That exposes the roof of Hunter's canal.
Cut the roof open.
Exactly. Incise that fascial roof, and you'll see the SFA and the vein. They're often stuck together pretty tightly, though. Needs really careful dissection to separate them.
Any pitfalls here?
Yeah, you often find large veins crossing over the artery. I gotta lag it and divide those. And remember, even if the SFA looks okay on scans, it often has some atherosclerosis, maybe calcification in the spot.
So be ready to extend the incision.
Always be prepared to go higher or lower to find a good, healthy segment for clamping and the anastomosis.
Okay, moving down past the thigh now to the popliteal artery behind the knee.
Yeah.
What's the lay of the land there?
So the popliteal artery is just the SFA continuing as it crosses behind the knee. Starts at the adductor hiatus, that opening in the adductor magnus muscle, and goes down to the popliteus muscle below the knee.
Anatomy is key here, I imagine.
Absolutely critical. Knowing the relationships between muscles, nerves, fascia, the artery, the vein, it's everything. The vessels run in a sheath, loosely connected to the tibial nerve.
And it's all packed in fat.
Yeah, the neurovascular bundle sits in the popliteal fat pad, can be quite bulky, especially in obese patients. And the popliteal gives off smaller arteries around the knee collaterals that link up with the DFA higher up. Important backup routes.
You broke down the exposures. Suprageniculate, above knee,
Okay.
mid-popliteal, and infrageniculate, below knee. Let's start above the knee, the medial approach.
Okay, suprageniculate medial. Patient supine, leg turned out, little bump under the knee. Incision is on the lower inner thigh along the front border of sartorius near the bottom edge of vastus medialis.
Or through an old vein harvest scar.
Yeah, if the saphenous vein was taken from there, you can use that incision bed. It's a bit more posterior then.
Yeah.
Cut the fascia lata, retract sartorius backwards, then incise the deeper fascia just below vastus medialis.
What do you usually encounter there?
Often a small artery and vein pair, plus a branch of the saphenous nerve. Usually divide the vessels, try to spare the nerve if you can.
Then you're into the popliteal space.
Right. Dissect into the fat pad, staying close to the back of the femur. The artery often feels firm, maybe calcified, even if the pulse isn't great.
What if it's hard to feel, like in an obese patient?
Finding the adductor magnus tendon can help. The artery pops through right there. Once you find it, get a vessel loop or tape around it for traction. Makes the anastomosis easier.
Where's the vein usually?
The artery is usually anterior and medial to the vein here. The vein often has bridging branches crossing the artery that need dividing. And yeah, like the SFA, expect calcification here too.
Okay. What about the lateral approach to the suprageniculate popliteal?
For that one, leg is turned inwards, knee bent. Incision is on the lower outer thigh, between the IT band and the biceps femoris muscle.
Cut the fascia lata again.
Behind the IT band, where it joins the intramuscular septum, you enter the popliteal space between the short head of biceps and the lateral femoral condyle, that bony bump.
Feel for the neurovascular bundle.
Yep. In the fat pad, you usually hit the popliteal vein first here. It's lateral to the artery at this level. Got to be really careful separating them. Watch out for the common peroneal nerve.
Right. Now, mid-popliteal. You mentioned the posterior approach is good here. Why?
Yeah, posterior approach is great for things like popliteal aneurysms or specific problems in that middle segment. Patient is prone, lying on their stomach, foot on a pad so the knee's slightly bent,
Consistency.
usually S-shaped. Avoids a straight scar across the knee crease, which can tighten up later. Runs from medial thigh across the crease down the lateral leg.
What do you find first?
Small saphenous vein usually. Ligate it or retract it. Cut the deep fascia vertically. Sural nerve often retracted laterally.
And the big nerves?
Tibial nerve is most superficial, retract that laterally. Common peroneal nerve runs along the biceps tendon, retract that laterally too. Then deeper and more medial, you find the popliteal vessels.
Artery and vein.
Yeah. You might need to retract the gastrocnemius muscle heads apart to see lower down. Artery is usually a bit deeper and medial to the vein.
Any limitations to this posterior approach?
Yeah, getting high up to the distal SFA, where it comes out of Hunter's Canal, is tricky. You'd have to divide part of adductor magnus and the artery curves away from you.
So maybe not ideal for really long aneurysms needing SFA control.
Right. For those, a medial approach, maybe extending the incision and dividing some muscle attachments, might be better.
Okay, let's go below the knee, infrageniculate popliteal. Medial approach first.
Right, infrageniculate medial, patient supine, knee bent, bump under the thigh. Incision starts at the knee joint level, about a finger width below the medial edge of the tibia.
Near the great saphenous vein.
Usually just above its course. Definitely identify it, avoid injury. If you're using the saphenous vein for the bypass, mobilize it first, then use that incision.
Then cut the crural fascia.
Yep. Incise the crural fascia to get into the popliteal space. You might see the semimembranosus tendon up high can divide that if needed. Retract the medial head of the gastroc muscle backwards.
And the vessels are there.
Neurovascular bundle is right under the medial edge of the tibia. You often see the medial popliteal veins first. Dissect the artery all around, get loops on it, separate it carefully from the veins, usually sharp dissection.
Any crossing veins here?
Not usually overlying the artery itself, but preserve any big collateral artery branches you see.
And the lateral approach below the knee.
Lateral infrageniculate. Supine again, leg turned in, knee bent, longitudinal incision over the head of the fibula, the smaller leg bone extending down.
Nerve alert.
Common peroneal nerve again. Find it behind the biceps tendon at the fibular head. Gently dissect it free, move it anteriorly. Then divide the biceps tendon to get to the fibula.
Detach muscles from the fibula.
Use a periosteal elevator, then divide and remove the upper third or so of the fibula.
And the artery is deep to that.
Exactly. Popliteal artery is right there. Dissect it free from the veins, get loops on it.
Moving further down, still tibial and peroneal arteries. Let's start with the anterior tibial. You said the very top part is tricky.
Yeah, the first bit, maybe 2 to 3 centimeters, it branches off the popliteal laterally and immediately dives through the interosseous membrane between tibia and fibula to get to the front compartment.
So hard to reach and often diseased anyway.
Pretty much. Surgical access there is rarely needed.
Okay, so how do you expose the proximal and middle thirds?
Usually a vertical cut on the anterolateral calf, the front outer side, centered over where you plan the anastomosis. The artery and vein run right on or near that interosseous membrane.
How do you find the right spot?
Relax the foot. Feel for the groove between tibialis anterior and extensor digitorum longus muscles, midway between tibia and fibula, maybe 2 to 3 centimeters below the fibular head. Cut there.
Incise the fascia.
Yep. Incise the muscle fascia above and below the skin cut, gives you room, especially in muscular folks. Watch out for the peroneal nerve again. Then blunt finger dissection between the muscle bellies.
And deep down is the artery.
Usually find the artery and vein right there on the membrane. Self-retaining retractors are essential. Watch out for small muscle artery branches, easy to tear. Veins often in front of the artery.
Other things to look for.
Small crossing veins over the artery ligate and divide. Lots of tiny side branches off the artery itself, dissect carefully. Find mosquito clamp, helps. Use small vessel loops for control.
What if it's really calcified?
If it's like a rock, sometimes a tourniquet is best. Exsanguinate the leg first with an Esmarch bandage, then inflate the tourniquet. Gives you bloodless control.
And the distal half, near the ankle?
Similar approach further down, but often if you have enough vein graft, the best spot is right at the ankle, just above the malleoli and the flexor retinaculum band.
Why there?
Tendons are converging, but you can usually find a path between extensor hallucis longus, big toe, and extensor digitorum longus, other toes. Artery and vein are usually easy to find there.
You mentioned tunneling grafts to the anterior tibial needs care because it's lateral.
Yeah, absolutely. Grafts from the groin need to be tunneled laterally, either subcutaneously under the skin or through the interosseous membrane. Bad tunneling leads to kinks, thrombosis, failure.
Subcutaneous is preferred.
Often, yeah. Tunnel across the front of the thigh, cross the knee at the midpoint of the lateral femoral condyle, stay anterior to the fibular head, avoid the peroneal nerve. Don't cross the knee too far forward or it'll kink when bent.
Keep the tunnel close to the muscle fascia.
Right. Gives good soft tissue cover, less kinking near the groin. Superficial tunnels, especially in obesity, can kink right at the top. Deep tunnels might get squashed under sartorius, sometimes need a counter incision midway down the thigh.
What about going through the interosseous membrane?
That uses less vein graft, which is good. Also, maybe less risk if the wound breaks down, especially if tunneled under sartorius, too. But you must make the opening big enough. No compression or kinking.
When is interosseous tunneling the only option?
For in situ grafts, using the patient's own vein in place, or bypasses coming from the popliteal down to the proximal or mid-anterior tibial, that's really the only way.
Can you tunnel across the front of the tibia for very distal bypasses?
Sometimes, down near the ankle, simpler but risky in thin people graft can get compressed against the sharp tibial bone.
Any tricks for making the interosseous tunnel?
Bending the knee 90 degrees, the sit-up position, helps. Lets you dissect from the medial popliteal space and the lateral anterior compartment at the same time. Use fingers, blunt tunneler, make the tunnel a bit beyond the anastomosis site. Some surgeons cut a cross shape in the membrane laterally, then use a curved clamp from the back to gently widen it. Careful not to cause venous bleeding.
Okay, shifting gears to the back of the leg again. Tibio-peroneal trunk, proximal posterior tibial, and proximal peroneal arteries. Where are they?
They're all in the deep posterior compartment, tucked under the big soleus muscle in the calf.
So how do you get there?
Usually start with that medial below-knee popliteal exposure we talked about. Find the distal popliteal, then use a finger or clamp to get into the space under soleus. Cautery helps divide soleus about a finger width behind its tibial attachment.
Tricky start.
Can be. Big veins hang out there, gotta ligate or suture ligate them carefully. But once soleus is divided, the arteries are usually easier. TP trunk is often behind its vein. Mobilize the vein.
Then the TP trunk splits.
Into posterior tibial, more superficial, easier to dissect here, and peroneal, which goes deeper and heads laterally towards the fibula. Lots of veins around here. Meticulous ligation is key.
Okay, focusing on the posterior tibial artery itself. How do you expose that specifically?
Medial calf incision again, 1 to 2 finger widths behind the tibia edge. Or use an old saphenous vein harvest scar. Incise the deep fascia, detach soleus from tibia with cautery, enter deep posterior compartment.
And the vessels are right there.
Usually. Posterior tibial vessels are immediately under soleus. Vein usually slightly above the artery, nerve behind both. Divide any crossing veins, control small side branches, loops for soft arteries, tourniquet if heavily calcified.
What about further down, near the ankle?
Much easier down there, below the soleus edge. Often preferred for ins-to fem-post-tib bypasses, can use the vein harvest incision. Cut behind tibia in front of Achilles. Incise fascia, find vessels in fatty layer. Doppler helps locate it. Lots of crossing veins again.
Got it. Lastly, the peroneal artery. Medial approach first.
Proximal part is easy, same as the TP trunk exposure. Find it at the bifurcation, dissect along its front surface, deep to the posterior tibial vessels.
Middle and distal parts via medial approach.
Yeah, medial incision, detach soleus from tibia again. Often needs a longer cut than for the posterior tibial, as peroneal is deeper, especially in muscular people. Find the posterior tibial bundle, then dissect deeper, either anterior or posterior to it.
Which way is better?
Anterior is traditional, but can be tedious with venous connections. Posterior has fewer veins, but gotta watch out for the peroneal nerve. Depends on the situation.
How do you find the peroneal artery itself?
Palpate the medial fibula deep in the dissection. Doppler helps pinpoint it. Often covered by flexor hallucis muscle fibers, might need to divide those. Vein is often encountered first, artery behind it. Lots of small crossing veins again. Retractors are a must. Often heavily calcified, anastomosis can be tough. Tourniquet, very useful here.
Sounds tricky. What about the lateral approach to the peroneal?
Many surgeons prefer it, avoids that difficult medial dissection, longitudinal incision right over the fibula, expose the bone, free all the muscle attachments with a periosteal elevator, careful posteriorly, don't injure the vein.
Then remove a piece of fibula.
Yep. Once enough length is freed, cut it with a rib shear, bone cutter, or oscillating saw. Saw is probably best.
Then cut the fascia underneath.
Incise the underlying fascia lengthwise. Artery is usually superficial to the vein here, easier to dissect, especially good for the distal half of the leg.
How do you tunnel grafts for this lateral approach?
Can go subcutaneous laterally, like for anterior tibial, or tunnel medially through the hole in the interosseous membrane where the fibula was removed.
Okay, we're finally down to the foot arteries. Distal anterior and posterior tibial exposures are important, you said.
Absolutely essential. For distal bypass targets, especially in diabetics, also for thrombectomy, for clots in the calf foot, and for access points in hybrid procedures.
What about the pedal arteries, proper dorsalis pedis on top, plantar on the sole?
Exposing them is usually straightforward because they're superficial, but they're small, often calcified, and need long grafts, so it's still challenging work. Requires precision.
But result can be good.
Yeah, if done well, patency and limb salvage rates are actually comparable to more proximal bypasses. Dorsalis pedis, DP, and the posterior tibial behind the ankle, inframalleolar PT, are both good targets. DP is often surprisingly spared from bad disease.
Key point about size.
Foot vessels taper significantly distally, so anastomose as far proximally on the target vessel as you can where it's bigger.
And they're connected.
Yeah, the DP and inframalleolar PT connect via the tarsal and plantar arches. So a bypass to one can often heal wounds supplied by the other. Good collateral network.
Quick anatomy reminder for the foot.
Sure. Anterior tibial runs down under the inferior extensor retinaculum, becomes dorsalis pedis. DP runs lateral to the big toe extensor tendon between first-second metatarsals, gives off deep plantar branch to form the arch with the lateral plantar artery.
And the posterior tibial.
Comes down behind the medial malleolus under the flexor retinaculum with nerve and veins, divides into medial and lateral plantar arteries, which also loop around to form the arch.
Endovascular versus open access down there.
For retrograde endoaccess, supramalleolar PT and pre-retinaculum AT are best. Further down, tapering and angles make it harder. Open exposure is sometimes better for retrograde work. A small 4 French access site can be closed with just 1 stitch.
And for Fogarty embolectomy. Getting clots out.
Distal ATPT cutdowns are better than going via the popliteal. Lets you pass the catheter up and down, less risk of distal emboli, avoids popliteal hematoma if patient's anticoagulated. Easy to control the arteriotomy with loops. Close with fine stitches.
Okay, let's expose the dorsalis pedis specifically.
Right, DP on top of the foot. Foot relaxed, maybe reverse Trendelenburg tilt. Need tiny retractors, good light, loops for magnification.
Incision.
Longitudinal, right over the DP, just distal to the retinaculum. Mark it with Doppler first if you can hear it. If not, go parallel and lateral to the extensor hallucis tendon. Pre-op ultrasound mapping helps too.
Nerves.
Might see the dorsal peroneal nerve, usually retract or divide it. Artery vein are under deep fascia, often palpable or visible. Length varies, preserves its tarsal branches, preserves side branches too.
Was it's calcified?
The bit under the retinaculum is often softer, good place for proximal control loop.
And finally, inframalleolar, posterior tibial, and plantar arteries exposure.
Okay, last one. Knee slightly bent. Foot up on towels behind the lateral malleolus widens the space medially. Curvilinear incision between medial malleolus and calcaneus. Doppler marking helps.
What's under the skin?
Fatty layer, maybe small veins to ligate. Artery is almost always calcified here. Feel for it under the deep fascia. Incise fascia. PT is bound by flexor digitorum longus above, flexor hallucis below.
Dissect down to the spleen.
Yep, down to where it bifurcates into medial and lateral plantar arteries. Divide crossing veins, crucial. Preserve the calcaneal branch to the heel. Can divide abductor hallucis muscle for more lateral plantar exposure if needed.
Wow, that covers a lot of ground. Quite literally down the leg and into the foot. Amazing detail.
It really is. You know, lower extremity arterial exposure isn't just one technique. It's this huge range of approaches, all tailored. Specific artery, patient factors, the procedure needed.
It requires incredible anatomical knowledge and meticulous skill for every single one.
Absolutely. Understanding the anatomy, paying attention to tiny details, that's what minimizes complications and gets the best outcome. Choosing the right approach depends on so much. The target, scar tissue, infection, body shape, whether you need vein.
It really makes you think, doesn't it? Considering all this intricate knowledge for these vascular procedures, what other routine medical things hold similar hidden depths?
That's a great point. How does knowing these details change how we see medical expertise, surgical advances? It definitely gives you a new appreciation.
Absolutely. A fascinating perspective indeed. Thank you for guiding us through this incredibly detailed deep dive.